Oh, hey, Chris.
Hey, Chuck, how are you?
Fantastic. Looking forward to recording another episode.
Yes, what's new in hand surgery part 2 for 2022?
There's a lot to discuss, including the highlight of your day, the pediatric fracture section.
You mean the peripheral nerve section, right? The very
Yes,
short
yes.
peripheral nerve section. Kelsey, I'm going to give you hell about this when you arrive for your fellowship.
Plenty of ink has been devoted to nerves, so I think we're prioritizing correctly.
And rightfully so. But any interesting cases recently?
I did have an interesting case. So as part of my responsibilities, I work in the peds division as well as in the hand division, and we have conference every Friday morning. It's actually a pretty cool conference. It is the all of the trauma cases for the week, and then selected pre and post operatives that are somewhat interesting or exciting or whatever. And the trauma cases are always fun. And on Friday we got into a discussion about, should you really care if you put a smooth pin across the distal radius growth plate for one of those displaced metaphyseal fractures in a 12-year-old? Does it really matter? Are you really going to shut down the growth plate? And we always have the same discussion. And my general answer is, I think if you put a couple of 6.2s or 4 or 5K wires across the growth plate coming from the styloid heading proximally, you don't do multiple passes, but you just get it right, I think the risk is infinitesimally small. And that was the discussion. And that's my perspective. And I think most people agree with that. I had a case a while back. The patient was treated elsewhere, and there were 3 or 4 large K wires placed across the growth plate. Large
like Steinman pin size wires?
Relative to the size of the radius, yes. And there was a growth plate arrest. Now, you never know if that was the fracture or the treatment, but in this case, it might have been the treatment. And in fact, I would think it is. And so this was still a young patient who had plenty of growth remaining. And so we had a significantly shortened radius with a normally growing ulna. And while, we certainly can accept some difference in forearm length, our choices were to, number one, take out the physeal bar. And that the success of that is more challenging in the radius, more successful in a larger physis like the distal femur. And in this case, the bar made up about 70% of the physis. And so that's too much. Also more centrally located. And so we gave the patient the choice of shortening the ulna and ablating the growth plate of the distal ulna, or lengthening the radius with an external fixture. And they did what I would have done. And again, perhaps I biased them, but we have started the process of lengthening the radius with an external fixture. It's a procedure I do relatively regularly that I really enjoy and really like, and it should provide some good outcomes. So I'm excited for the patient.
Now, is that a uniplanar frame?
Yeah, so I use uniplanar frames on the forearm. I use them on the metacarpals. When basically a circumferential frame or circular frame is required, we're fortunate to have a couple of outstanding partners who do this all the time. Typically use the Taylor spatial frame. We use that in the upper extremity as well, but they apply it and they manage it.
So what's the rate of growth that you expect in terms of the osteogenesis?
Yeah, for the distal radius, classically you hear about a quarter turn a day, with each quarter turn being a quarter of a millimeter. So 1 millimeter a day lengthening, about an inch a month when you do the math. I think it's a little slower in the distal radius in the hand. I do about three turns a day is my typical. And then consolidation, people say, is twice as long as the lengthening phase. So if you lengthen for 6 weeks, you expect 3 months for consolidation. I don't think it's quite that much, but those are the numbers I talk about with patients, because it is not easy to have a frame on for that long.
Now, what is the reason that you go at that pace? Now, obviously, the nerve surgeon in me is saying, how are you going to evenly distribute this extra tension across the nerve if you're lengthening the radius? And is that related? Because a millimeter a day sounds awfully familiar to me.
Of course it does. Everything does. It goes back to nerve. No, thankfully there's almost never, I don't recall a nerve issue at all with lengthening. It's purely about the body's ability to make bone. That's it. It's not, Chris, about the nerve.
Well, it was interesting at the I attended the ASPN meeting virtually this year, and during the kind of poster session they do at cocktail hour kind of thing, there was a case that was presented at the very end that was a sciatic nerve injury that was treated, which I had never seen before. With instead of doing a graft for the largest nerve of the body, which clearly is going to have some issues, direct repair of the sciatic nerve accomplished through shortening of the femur over a rod and then eventual re-lengthening distraction of the femur. And it was a case that I was kind of, wow, I would never have thought that would have worked. And clearly this ended up working. Otherwise they wouldn't have shown it, I would think. But the rate of distraction osteogenesis was dictated by the potential growth, the growth rate of the nerve.
I have not considered that type of treatment in any of my patients. And while it's interesting, I'm not sure my patients would line up for that choice. But
Well, old school treatment of radial nerve palsy, you would shorten the humerus as part of the treatment to get a direct repair. So
no, I totally hear you. I totally hear you. That is something. And
I'm
let's
sorry I
not
took it.
took it back to nerve.
I was gonna say sorry I took it back to nerve.
Of course you did. But hey, I mean, the sciatic nerve is vitally important, and whatever is necessary to get a good outcome, is I guess in play.
So what's the teaching lesson, when you're presenting this case in conference? You mentioned that this was we're talking about case conference for peds and, the Steinman pin or the K-wire passes and that. And the case you presented was different, was treated elsewhere. What's the teaching point for the residents and fellows in terms of, the use of pins for distal radius fractures that you've reduced?
So pins are appropriate, and there is certainly a way to place your pins avoiding the growth plate. Usually when you see that metaphyseal fracture, you typically see one pin entering just proximal to the growth plate, and that's a retrograde pin. And then the other pin is an antegrade pin from the radial side of the radius heading up and across. The problem with that approach is neither pin has a perfect bite, and so the cast becomes more important. And you can be very successful with that mechanism. I would argue that you can be just as successful, excuse me, perhaps even lower risk with two retrograde smaller K-wires, not small, but smaller through the styloid across the growth plate into the proximal fracture fragment. And you don't want to use pins that are too big. You don't want to repetitively drill, but I think you can be very successful with incredibly low risk.
Just get it right the first time.
Get it right. I mean, honestly, though, you just need to get it right into the epiphysis, right? And then when you have that, then you're done, and you can feel safe driving it across the growth plate and across the fracture.
We are going to talk about growth plate trauma as part of the pediatric fracture section. So that was a nice segue. But to continue going in order on the What's New in Hand surgery article, they talked about wrist trauma next.
Yeah, and I think this first paper is interesting. Acoli et al. Looked at 134 patients treated with a volar locking plate and non-operative treatment of ulnar styloid fractures, and outcomes were the same. Does that match your experience?
Yes, and that's why I did not find this article to be very interesting. Yeah, I mean, I think that it's not so much the styloid fracture, it's the either styloid or the neck fracture with frank instability. And I think it's the stability of the DREJ that matters. And then for the fractures that are slightly more proximal, kind of distal shaft getting towards the neck, it's whether there's residual displacement of that fracture, after you fix the radius.
So I think this is yet another example of a paper which is useful. It does confirm what I guess 10 years ago would have been very controversial. And so I think the lesson here is don't look at the size of the ulnar styloid fracture. It's not a matter if it's the tip or the base. I mean, look at those things, factor them in. But what really matters is what I know you do and what I do is you fix your radius fracture as you normally would, and you examine the DREJ. And if your ulnar styloid or distal ulnar fracture looks okay, and you have instability, my first choice is to try to find a position such as supination that provides stability, and then I immobilize them in that position. But I try not to treat it at all, and it doesn't affect my postoperative care if the DREJ is stable.
So it's interesting. We talked in a conference, our hand conference, about, how much it matters to lose certain motions. So we live more in a pronated world than we used to. If you're splinting them in supination, why not just fix the styloid fracture and see if you can keep them in neutral instead, or not immobilize them across the forum?
I think fixing the styloid fracture and getting it to heal is another big step in the surgery. I honestly don't think it's the simplest thing. There's all kind of different techniques, and when there's all kind of different techniques, it doesn't always mean one of them's best. And so, if I can get away with avoiding surgery there and doing 3 or 4 weeks in supination, I think then you can expect full return of rotation, and I think you're better off, honestly.
Okay, so maybe it wasn't as plain vanilla and boring of an article as I thought. One thing that I have to remind myself of when I'm talking to patients is always to remind myself to talk about the ulnar styloid fracture, because of all the literature. Like, we take it totally for granted, but a patient has no idea, and they see their X-ray, and if they're astute, they'll look at the fracture, or they'll look at their report more commonly and say, well, why wasn't this other fracture fixed?
It is highly relevant because in my practice, the fracture's healed or healing at 6 weeks, motion's getting better, and the ulnar sided pain persists. And so the sooner we mention that and explain that everything's going to get better except for that ulnar sided pain, and that can be 6 to 12 months, patients don't ask about it anymore. You just have to get it out there.
Do you have a role for a steroid injection to help with that pain?
I have not routinely done that. I haven't found it necessary because patients accept that it'll get better with more time. What about you?
You just tell them to suck it up?
Suck it up, be strong.
I actually had not. One of our partners, I think, it does it, and I had not heard of it until it was mentioned in conference one time, and I said, "Oh, well, that might be a reasonable option."
What'd you think of the next paper, which I thought was a little more interesting, in which Clifto looked at 192 patients with a distal radius fracture and evidence on X-ray of scapholunate interosseous ligament injury. The fracture was treated with the volar locking plate. The scapholunate ligament was ignored, and there were good outcomes at 12 months and 24 months, and no difference whether or not there was a scapholunate injury.
Well, I mean, I think I'd have to read the original paper in detail, because I don't know whether they looked at other signs of the scapholunate instability. Just widening doesn't mean that there's instability. Could be wide on the other side. So maybe they took that step, maybe they didn't. What's the SL angle? What's the is the lunated extension? All these kinds of things, because those are the things that I look at when I see a patient with a distal radius fracture and SL widening, like a gap there. And then also the fracture pattern. Is it a chauffeur type fracture with the radial styloid where you clearly see the fracture line heading right in towards the SL interval? Or is it your standard metaphyseal distal radius fracture, bending type fracture with a little bit of intra-articular extension? Those are very different things. So I'm not surprised, to be honest with you, if it, unless they took tremendous care to go into all those different nuances, that there was no difference. And honestly, you're immobilizing most patients for a fair bit of time after this anyway, so probably that helps if there is even some kind of ligamentous injury at the carpus.
Yeah, and let's be honest, it's probably not the 24-month follow-up that matters. It's probably the 5-year, the 7-year, the 10-year that matters to know if it really is impactful for future carpal health, so to speak.
So one article that caught my eye here was talking about, we talked about this in the past with a prior case that I had encountered about flexor pollicis longus rupture after volar plating. And this article by Moriyama talks about the average time to see flexor tendon rupture as 9 years after volar plating in an elderly cohort. Does that match what you've seen?
Well, I have been doing this for a while, and I have been using volar plates for a while, and honestly, it's uncommon to see them, right? But yeah, they happen a long time after plate placement. Part of that self-selected, right? We take out the plates we believe are way too distal, and I think that feels right. What about you?
I think that sounds right, and it's terrifying to me as a surgeon, because honestly, like, a patient doing well with the volar plate, even if I position it exactly where I want it, I discharge them pretty early. I'll be honest with you, don't see a lot of these patients after 2 or 3 months from surgery. If I'm confident in how they've recovered, and if I'm confident in the position of my fixation, and I don't routinely take out plates that I like the position of. So while I counsel them about this possibility, they're not going to remember that in 10 years, like to be very honest. And that worries me because that's an average of 9 years. So it could be 20 on the other end of it.
It's super interesting. It's an important point though that all of us should bear in mind. And there's a lot of there's a couple other interesting papers, and there's some that probably we don't need to dive into. I do think very briefly, or I should say, I could do better with bone mineral density testing in my patients with distal radius fractures. I try to be good and try to tell every patient with a fracture to see their primary care doctor, or I send them over for testing. But I have to say, I'm not positive every patient is taken care of the same way, and that's on me.
I agree. And I've gone through phases where I'm very good about it. And I've gone through other phases where I'm not great about it. And it is often reading a paper like this that reminds you to do it. So this paper looked at, the fracture-free interval after a wrist fracture. And whether they got a bone mineral density test, the average time until their next fracture was 819 days. And if they did not get a bone mineral density test, the average time was 579 days. So you're looking, roughly a year, maybe, and that's something where we as hand surgeons and orthopedic surgeons in particular can be much better at in terms of so-called owning the bone. And I admit that sometimes it's very difficult to get your patients into bone mineral density testing. And in an academic center, it's also tough. You don't want to kind of get into referral patterns too much in terms of who should be doing this, endocrinology versus us in orthopedics. And it just becomes a little complicated. It'd be nice to set up a very easy pathway, and it's probably something we should look at.
I think we probably should, and it should become part of just our standard algorithm. And the problem, of course, is you don't want to add one more thing to a patient's mind when they're being treated for a new distal radius fracture. And so really it's probably at that, maybe we do it at the 6-week visit or the 12-week visit, if there is one, or the 6-month visit, if there is one. But you don't have to do it, right away, but we should probably do it.
I'll be honest, I often am better about asking if I have a trainee with me.
There's many advantages to trainees, and that is exactly one of them, for sure.
So how often are your distal radius fracture patients returning to yoga?
Well, hopefully often, but that gets back to the last point. When they, obviously the yogis, is that the right way of saying it? They need that wrist extension, which is the benefit of early motion. And hopefully I can say that most patients get satisfactory wrist extension. But when they do go back to early yoga, it is the ulnar sided wrist pain, which gets them if they do it too soon.
For sure. I found this paper to be useful because I never know how long to tell them, how long it's going to take to get back. So, they mentioned 90% return to yoga at a mean of 7 months. So to me, that's a useful factoid that I will indeed incorporate into practice.
I think it's a nice little number that's easy enough to remember. Should we jump to, there's one article mentioning on scaphoid fractures, and I don't know, you and I think we've discussed it maybe at Journal Club,
Yeah, we did.
which I thought was a good discussion. It's a discussion of a really nice randomized trial of scaphoid non-unions treated with corticocancellous versus cancellous only bone grafting. There was no significant difference in healing, but cancellous only did have a higher malunion rate. And the corticocancellous also demonstrated better quick dash scores. So interesting. I'm a cancellous only, but I recognize there are some benefits to the corticocancellous.
Yeah, I think that the corticocancellous obviously gives you more support for deformity correction, but I think that if you get your deformity corrected, and that's part of it, you're not just putting the screw in when the scaphoid is flexed. That's going to be a huge consideration. I think that most of us start to get a little more concerned and alarms go up when we see the scaphoid flex and that higher intrascaphoid angle. And that's when I honestly would think more about using something that's structural as opposed to purely cancellous bone.
Yeah, and I'm trying to remember, I'm not going to remember it. There is an article which discusses the quality and the kind of, I guess, the induction properties of distal radius bone graft versus iliac crest bone graft. It's really interesting because I have to admit, as much as I hate going to the crest and I don't do it often, it's better bone.
It is. But, and also I would love to see, I was doing a combined case with lumbar trauma colleagues, and I think one of their now sources to go to is the distal femur, and I've also seen people take from the tibial plateau, proximal tibia. So that has a lot of the advantage I think you would get from the crest without the god awful pain from the crest. That being said, I did have one patient who fractured through that distal femur site because I was taking care of her for something else. So that clearly has its issues. So I may just stick with my distal radius for now.
Yes, listen, it works and most of these patients heal, but it's an interesting thing to think about for sure.
So we should jump to an article that you actually talked about in our congenital episode, our first of many congenital episodes. But you talked about Doug Hutchinson's article about trigger thumb. You want to summarize anything that you didn't touch on last time?
Yeah, so Hutch is a hand surgeon in Salt Lake City. He's been a friend for a long time, and this was a kind of a passion effort. He essentially stopped operating on trigger thumbs to see what happens. And he said he enjoys his practice more not operating on every trigger thumb, but I honestly don't know that the results were as he expected. The impetus behind this paper is interesting because essentially Dr. Beck, who is from South Korea, a senior surgeon there, had written an article saying that you don't need to operate on these at all. And I was running some course, and Hutch and Beck were kind of on a debate, one side versus the other. And I think it was the impetus for his study. And he looked at 93 thumbs, 78 children, followed over 5 years. And so essentially, what he found was that about a third had spontaneous resolution, and nearly half proceeded with surgery, but at a median of 4 years after presentation, which is super interesting. I think the takeaways are that risk factors, and this is what I will take away, if it's more than 30-degree IP flexion contracture, and if it's bilateral, then I think we all feel very comfortable moving ahead with surgery. Unilateral, less than 30 degrees, maybe give it a chance to resolve.
Now, have you incorporated that into your practice?
I mentioned that to families. The vast majority of mine are bilateral, so which again puts you a little towards surgery. I don't, again, it's not a knee-jerk surgery. I generally send patients away and say, if in 6 months this is still a problem, call or come back and we can set up the surgery if you like. But this is just one more bit of information. I think this was a very patiently done study that, in our era of trying to get quick results, it's hard. So I really applaud him for this.
Speaking of surgeries that don't bring many people joy, what about this article on mallet fingers? So for many of us, we've been shying away from surgery because study after study is showing it doesn't matter the size of the mallet fragment. What matters is joint subluxation. But now this study is showing that even with DIP subluxation, the outcomes are no different for a mallet finger. So what did do you believe that, or is there any reason in 2022 to operate on the mallet finger?
So this is interesting, and I'm aware of this paper, and I've carefully reviewed this paper. It was extraordinarily well done. And as you said, the size of the fragment and the alignment of the joint did not affect outcome. The joint was subluxated in 50 patients. It was congruent in 168 patients, and motion and general evaluation did not differ. And so the authors recommended non-operative treatment for all. I have to say, one of our partners would say the same. Lindley Wall believes that these patients can generally be treated without surgery. It's a hard one for the surgeon to look at a large fragment. It's a hard one for the surgeon to look at a subluxated joint and ignore it. And it's hard for families.
I was gonna say it's not just the surgeon, it's the family and the patient. Patient sees the X-ray. I mean, they see that there's a big fracture that you're not fixing, and they might pick up on the fact that the joint is subluxating, but they're going to focus on that fracture.
Yeah, and aesthetics matter. Having a big bump there matters. So it's a little hard to believe, but it's not, I believe it. It's just a little hard to reconcile, I think, with what I see. So I don't think it's quite that cut and dry, but I'll tell you, it does make me reconsider my surgical criteria and go a little slower.
Right. My criteria, I very, very rarely will operate on a patient with a mallet. So I like this paper, but it's a tough discussion to have. It honestly, just getting to the root of what we do as surgeons, it actually is more time to talk to patients about not having surgery than it is to talk to them about surgery.
Yeah. Oh, well, that's for darn sure. Always has been. And as much as we've joked about the pediatric section, what I'd like to do is jump ahead to nerve and round out this. Well, nerve, and then we should talk about equity. I think that's an interesting section briefly. But tell me your thoughts on I guess as it was labeled, spontaneous peripheral neuropathies such as Parsonage Turner, and the timing of surgical intervention.
I think this one comes down to, the patient's personality, their willingness to do something, and then the circumstances surrounding their nerve palsy. Patients don't love jumping back into another surgery after they've just gotten over their first surgery. And there's definite, that plays into the decision-making calculus for patients, as well as my willingness to offer them another surgery. It is often not a slam dunk, let's do surgery, you're going to get better. It's more of a, let's do surgery because there's nothing else to do about it. And I saw a patient like this recently where we're just continuing to watch their postoperative nerve palsy that is unrelated to their surgery. It's not because the nerve was injured in surgery. It just is out. And it often is the AIN. And it's very tough to sit there and watch it. But I'm not sure that surgery is going to alter the natural history, although these studies would suggest that there may be some role for that early on. The problem is, it's not necessarily whether you're going to do a decompression to me, it's whether you're going to do something more. Because if you're going to jump in and say, let's do, and some would consider doing something like a nerve transfer, at least reverse end to side, theoretically don't lose anything. You have a window of time in which you can do that, in terms of theoretically, if the electrical has been cut off to that muscle, you have a window of time before denervation related atrophy sets in and you lose that opportunity. So to me, the decision is more, are we going to do something more? Because I'm oftentimes, if I'm going to do a decompression, I'm probably going to consider doing something more. Now, as I talked to this patient about it last week, it was more of, okay, if we go in and we decompress it, I'm going to stimulate the nerve. And if I get a good response, that's it. But if I don't get a good response, or if it's a feeble response or it's no response, then maybe we're going to consider doing a nerve transfer because I'm there and that opportunity to do it is right then and there. And I think that is one consideration. And I think one of the other articles that wasn't in this year's, but was in the past year, was the concept of microneurolysis. So basically doing a neurolysis using a microscope to find smaller constrictive bands that circumferentially run around the nerve that Scott Wolf and Steve Lee have found with their the high resolution ultrasound and their advanced MRI. And that's super interesting to me as well. But I think this is an area that's still evolving. It doesn't come up enough where there's a big impetus to study it, but clearly, we're still trying to figure this one out.
Well, and you were nice enough to give me advice on a patient not in the not too distant past that had the PIN palsy spontaneously, and that I think we waited out. And I think ultimately he may have followed up with you. But yeah, it comes up occasionally, and when it does, it's a big deal for the family. And this is helpful, I think, at least to some degree. But I like your algorithm.
Yeah, it's really super interesting, this condition. And I think that, I know Scott Wolf is spending a lot of time studying this now. It's kind of one of his passion projects, and I hope that more comes out from that work. And I'll be honest with you, I think the rest of the articles in the nerve section were not as interesting to me, be very honest. But there were a couple of good ones. I mean, I think that it was surprising that in clinical evaluation of patients with nerve injury, complete nerve transections were missed in a third of the patients, which is shocking, but not that surprising. If that makes sense.
Yep, totally. And then the other was processed nerve allograft performed better than conduit in both small and large gaps in terms of functional recovery. I don't think that surprised you.
No, and I don't think that's the question anymore. Like, I think there have been enough studies showing the utility of processed nerve allograft in gaps of this size. They call it large, but 15 to 25 millimeters is not large. I think the question now in 2022, and it's been for a couple of years, is what's the role of processed nerve allograft relative to an autograft? And I think that continues to be a question of interest. I think there are passionate people on both sides of the argument. And I think that it's important to consider conflicts of interest of those who are discussing on both sides.
Yeah, I love that. I love that. And maybe just in closing, I'll say there's a nice section on equity policy and education, which emphasizes what we all know is that there is more work to be done. And I don't want this to be an afterthought because this is really important, but there's more work to be done on gender and racial inequity in our profession. And there has been progress. The Hand Society is better than most parts of orthopedics, let's be honest. But certainly needs to be further improved. And so I look forward to watching and doing what I can to help with that progress.
Absolutely. I mean, in addition to the articles that are included here, Lauren Wessel, our fellow from last year, and I looked at the representation on Hand Society panel submissions. And this was in a year where Amy Moore was the co-chair. So Amy was a co-author on this paper too. And it just came out in JHS Global Open, Global Online. So in JHS Go, we just published the fact that the subtle, not so subtle encouragement, i.e. requirement that you include people from underrepresented backgrounds on your panel submission, surprise, led to significantly greater representation of women on ICLs and symposia. So I think that's, it's a small but important example of a simple policy type thing that groups can do to address a larger problem.
Yes, well said and well done, Lauren et al. On that paper. Congratulations, Dr. Bohn. Congratulations, Dr. Wise. I think this was a great edition of the annual update on hand surgery. And as usual, I learned a bit.
I learned a lot. It was great to read. I can only imagine the amount of, well, actually, I know the amount of work that goes into that. So congratulations to both of you for that, and look forward to next year.
Absolutely. I got a win for you for the week.
Yes, let's see it.
It might be a little corny. My win is that I appreciate my team. We are not islands and we cannot function alone. And I am fortunate to work with a great team, a nurse who's extraordinary, therapists who are fantastic, and Karen, who kind of keeps my life together. So I'm grateful for my team.
That's fantastic. Well said, and obviously super important. And even, in the era of COVID and everybody wanting to change jobs, you have managed to keep your team together. So congrats on that.
Gonna try to keep it going. What about you?
My win is the fact that, we finished conference early one Monday and I was on my way down to our South County location and I felt like having a donut. So I stopped and got a donut, and I decided to get donuts for the team, support a local business, and that's now turned into a donut competition in South County. All the various clinic teams are bringing in donuts from different places throughout the South County region to compete and see who has the best donuts. So we got a whole rating board. We got, there's a scoring system, and shout out to Gene Szerzinski, who has put that together. And I know that you worked with Gene for many years, so it does bring, honestly, it's fun. And it brings a little morale lift during what can be a kind of a tough time.
You know what? I think South County has a lot of donut options, more so than our area of the world, and I'm jealous. And maybe it's something to try to do. I don't, Dunkin' Donuts is the closest to me.
And I will say, I will close with one thing. I had a patient come in, and shout out to you if you're listening, who I was going through my whole spiel about carpal tunnel syndrome and the release. And she's like, I know, I listened to your podcast. And she was quoting back things that I said. And I'm like, oh my goodness, I hope I remember what I said on the podcast. But if you're listening, I hope that you've enjoyed the podcast, and thanks for listening to the end.
That's awesome. All right. It's been fun, and I'll see you soon.
All right. See you next week.
All right.